Hello, my name is Rachel Aragon, and welcome to my psychopharmacology case presentation regarding olanzapine. Let's jump right in and start talking about the basics. Olanzapine is an atypical antipsychotic second generation medication approved by the Food and Drug Administration for the treatment of schizophrenia, acute maniac, or mixed episodes seen in bipolar disorder in adults, as well as maintenance treatment for bipolar disorder. The mechanism of action for atypical antipsychotics are not clearly understood. However, it is thought to block serotonin receptors in the cortex, which diminishes its ability to inhibit the dopamine release. This leads to more dopamine in the prefrontal cortex, which helps alleviate the negative symptoms of schizophrenia. Wu and Win, 2012. This atypical antipsychotic also blocks transmission at the D2 dopamine receptor and is effective in treating psychotic symptoms without the side effects of motor impairment. Mehta et al. 2019. Antipsychotics like olanzapine have less of a D2 blockade, which results in a lower risk of extrapyramidal side effects. Wu and Win, 2012. Olanzapine is also a strong histamine H1 receptor antagonist, which adversely causes more waking as well as sedation. Because it is very sedating, it should be given at bedtime. Wu and Win, 2012. Atypical antipsychotics also have modest cognitive benefits, such as improving working memory, attention, as well as verbal fluency, likely due to their affinity to various serotonin receptors. Mehta et al. 2019. Olanzapine is metabolized in the liver and excreted renally. Typically, olanzapine peaks in 6 hours and has a half-life anywhere between 21 to 54 hours. Wu and Win, 2012. Now, in our first case study, we will be meeting Miss Catherine. Catherine is a 27-year-old African American female who presents at her primary care provider's office, accompanied by her mother and sister. Her family has had concerns over her behaviors over the past year, given her lack of motivation, inability to hold a job, as well as her delusions of saying the FBI is out to get her and has planted recording devices in her home and car. Her family reports that her speech at times doesn't make sense. These behaviors have lasted over 6 months. However, Catherine has refused to seek treatment prior to this encounter. Unfortunately, she's lost contact with many of her friends and keeps to herself most of the time. Current medications: Haley, 1.5/30 for contraception. Past medical history: non-contributory. Allergies: sulfa, which gives her a rash. Family history: father does have a history of schizophrenia, no history of diabetes or cardiovascular disease in her immediate family. Substance use and abuse, denies. Developmental and social history. For a patient and family, she says she had a normal childhood, however, has a hard time making friends and long-lasting connections. Mental status exam: she has a blunt affect, poor insight and judgment. Assets and liabilities: she has wonderful family support. Her mother and sister are very supportive of bringing her in, and in fact want to take her in sooner, but she had refused. They show great care for her. Physical exam: blunt affect, decreased hygiene, overall but pleasant. Differential diagnoses: delusional disorder, major depressive or bipolar disorder, schizoaffective disorder. We would also need to make sure we're ruling out any other medical, neurological, systemic illness and/or substance abuse. The diagnosis we're coming to is schizophrenia, and treatment plan: we're going to start olanzapine 5 milligrams every day. We'll get some baseline labs, including fasting blood glucose and lipids, her weight, monitor her blood pressure, do a pregnancy test. Patient and family education would, of course, give informed consent regarding the medications, risks, benefits, side effects, and treatment plan. And referrals: we're going to definitely consider cognitive behavioral therapy, social skills training, and possibly vocational services to help with goals of possible employment. Now, let's meet Fred. Fred is an 89-year-old Caucasian male currently living in a boarding care with a diagnosis of Alzheimer's dementia. Recently, facility staff have been reporting increased agitations, hallucinations, and delusions. At times, he has gotten back with the caregivers while they tried to assist with bathing. I received a call from the facility staff stating that I need to do something about this. Current medications for Fred: Warfarin 2 milligram tablet, 1 tab PO daily. Lasix 20 milligram tablet, 1 tab POQ day. Benazepril 10 milligram tablet, 1 tab POQ day. Carvedilol 3.125 milligram tablet twice daily. Duoned nebulizer treatment 4 times a day. Spiriva treatment every day. And Aricept 10 milligram tablet, 1 tab POQ day. Past medical history includes atrial fibrillation, myocardial infarction, coronary artery disease, congestive heart failure, COPD, as well as dementia. No known allergies. However, family history shows that his father has had heart disease. He denies any substance use and abuse. Developmental and social history. He currently lives in a 6-bed boarding care facility. His wife lives nearby but is unable to care for her husband, unfortunately, due to her own medical needs. Diagnostic tests. He's had his MMSE completed, which scores 15 out of 30. Mental status exam. This patient was only alert to himself. He was very pleasant, conversational. However, he lacked insight and judgment. Assets and liabilities. Luckily for this patient, he lives in a boarding care facility where he has great 24/7 caregiver support. Physical exam, again, he's only alert times 1, pleasantly confused. Differential diagnosis. At this time, because these are new symptoms, we want to make sure that we're ruling out infections such as a UTI or pneumonia. So we are definitely going to get a UA-CNS, and his diagnosis ended up being a urinary tract infection, which at this point we will treat with a course of antibiotics, Cipro 250 milligram tablet, 1 tab PO, BID times 3 days, encourage fluids, and of course reassess for behaviors. Now, if the behaviors still continue after we've cleared the infection, then we will definitely work him up again. At this time, no referrals are needed. So olanzapine would not be appropriate in this patient population, especially because there has been known to have increased mortality in elderly patients with dementia-related psychosis. When these patients are treated with an atypical antipsychotic, they are at an increased risk of death compared with placebo. Most common causes of death were cardiovascular or infectious, which is the reason why olanzapine is not approved for this population. Second-generation antipsychotics are preferred for the management of schizophrenia as they carry less risk for the extrapyramidal side effects commonly seen in first-generation antipsychotics, but they do increase the risk for metabolic syndrome, including insulin resistance, weight gain, hyperlipidemia, and diabetes. Yu et al. 2019. Olanzapine is a second-generation antipsychotic, which is widely used. However, there has been known to have more metabolic risk as compared to other second-generation antipsychotics. A systematic review of 40 studies was completed to assess insulin resistance of second-generation antipsychotics in China. As compared to aripiprazole, ziprasidone, and risperidone, olanzapine was found to carry a higher risk of metabolic side effects such as increased fasting blood sugar, insulin resistance index, and fasting insulin levels. Yu et al. 2019. As a result of the known metabolic side effects of second-generation antipsychotics, it is recommended that patients be screened regularly for weight gain, type 2 diabetes, and dyslipidemia. Li et al. 2016. Clinicians should monitor body mass index before starting olanzapine at 1 month and quarterly thereafter. Blood pressure, fasting blood sugars, and lipid panels should also be assessed prior to starting olanzapine and at 3 months annually. Wu and Win 2012. Common side effects of this medication include somnolence, sedation, weight gain, in addition to dry mouth, dizziness, and gastrointestinal changes. Extrapyramidal side effects such as tremor, muscle stiffness, as well as hyperprolactinemia may also occur. Olanzapine has a lower risk of what we call neuroleptic malignant syndrome due to its higher affinity for serotonin receptors and lower affinity for dopaminergic receptors. Sahu et al. 2017. While neuroleptic malignant syndrome using olanzapine is rare, the clinician should also be aware of signs and symptoms of this condition and educate appropriately. These symptoms include muscle rigidity, fever, altered mental status, and hemodynamic instability. Bromocriptine is used for treatment of neuroleptic malignant syndrome along with other supportive measures. One of the main issues seen in prescribing antipsychotics is the potential for non adherence to the treatment regimen. Due to the lack of adherence to medications in patients with schizophrenia, there has been research to see if therapeutic drug monitoring using reference agents can help determine if the poor clinical response is a result of progression of the disease, medication non adherence, or drug ineffectiveness. Correll et al. 2018. Additionally, there are different formulations of olanzapine, including a long-acting injectable that could be helpful for those patients non-adherent to oral medications. Injectable olanzapine is FDA approved for agitation related to schizophrenia and bipolar disorder. There is also a long-acting injectable approved for the maintenance of schizophrenia. Regardless, there is not a one size fits all approach to managing schizophrenia. Drug selection must be individualized to positively impact patients' quality of life as well as function. Cultural diversity is also very important because understanding one's culture can provide insight into their behaviors. If the behavior question is part of one's culture, it may not be alarming to the clinician if they were aware of the cultural context. So that is definitely something that we need to be mindful of when we are managing patients of different backgrounds. In summary, managing patients with schizophrenia using medications is very important that we commit to creating a therapeutic alliance with the patient as well as their families. Again, we can come up with a great treatment plan in our head, but if our patient is not in agreement or maybe they don't understand it fully, the treatment plan will fail. It's so important to make sure that we are providing true informed consent, that they know the risks, benefits, conditions of all the medications and treatment plans. Important that we monitor closely and follow up on these medications and realize that pharmacotherapy is just one piece of the puzzle. It takes a team approach to manage these patients and make sure that they're getting the best quality of care. And lastly, my references. Thank you for taking the time for viewing my presentation. Looking forward to any feedback that you may have.